Good morning. So today's class is about cytopathology. So before I start telling you about what cytopathology is, let us just brush the fundamentals. So we know pathology means is nothing but study of diseases, and now this pathology has different branches, and in that some, to name a few, are cytopathology, histopathology, molecular diagnostics, hematology. Okay, so now all of you, I'm sure, must know what is histopathology. So histopathology is nothing but the study of the biopsies. Okay, so biopsies means we are studying the tissue. So if we go through our basics, we know that our body is composed of a lot of cells. These cells join together to form tissues, and these tissues join together to form the organs, and organs join organ system, and so on. Okay, so here in histopathology, what is happening is we are studying the tissue, that is a group of cells which form the tissue, and we study not only one tissue but also the adjacent tissue. So as a group we are studying about it, we are identifying it as normal or abnormal, and then we are giving out the report. But in cytopathology, what we are studying is we study cells. So if you break cytopathology, okay, it is cytopathology. Cyto is cell, pathology is study of the disease. So you're trying to identify a disease in a person but just by studying the cell. So now by studying the cell, we can tell whether the person is not having any problem. If the person is having a problem, what can it be? It can either be an inflammation, or it can be an infection, or if it is a neoplasm, whether it is benign or it is malignant. So all these details were just by studying the cell, and that is what forms cytopathology. The technique which we do to study about the cytopathology is something called as the FNAC, so which you can see in this picture, fine needle aspiration cytology. So very simple, I'll just show the pointer. So here you can see this is the cell which we are studying, like here we can see there's a cell. So this kind, each cell will be studied. So there are certain characteristics which we all have been in the literature, and we compare them and we read. And here we can see this is the technique which they are using it, like the cell, the syringe, you have a piston, and you also have the slides where you make it, and this is the method by which the smear is done and the cells are studied. So this is just an outline of the class today. In subsequent slides I will tell you in detail like how we process the tissue, how we take out the sample, how we study it, and how we interpret a result. Okay, so this is the class study today, where we can see what we'll be doing is first is with the introduction, second about the advantages of FNAC or the cytopathology, second is on the limitations, fourth is about the equipments which are required to perform the procedure as well as to process and to report the particular slide. The next thing is about the FNAC technique, and then about the processing, fixation and staining, and the last of all a few lines about the complications of the procedure, or the complications of or the disadvantages of the FNAC or cytopathology per se. So introduction. FNAC, as I stated, stands for fine needle aspiration cytology, is a technique whereby cells are obtained from a lesion using a thin bone needle, and smears are made for cytopathological diagnosis. This technique is based on the fact that tumor cells are less cohesive and are easily aspirated. So on this point, I would like to tell something also what is called as cohesive. Cohesive means cells stick to each other. So whenever the organ is normal or this condition is benign, all the cells stick to each other and they are very adherent to each other. But whenever some kind of infection or inflammation or some kind of malignancy sets in, what happens is the adhesiveness of cells to each other is lost and they become far apart, or they are separated, and that is what is referred to as a discohesive, which is a very characteristic feature of malignancy. So taking into account this feature, the cytology came into existence, like because these cells are separated, it is very easy to aspirate them from the body and you can study them, and these cells will show a lot of different features, like there will be cellular pleomorphism, nuclear pleomorphism. So all those which we have read in the neoplasm lesson, all these features can be seen but just by identifying the cells. So it gives us to a clue as what can we be dealing with. Okay, so that is the point which I want to tell about cohesiveness here. Next, where all can we use it? So any accessible lump. So if you take in the head and neck region, your lymph nodes, thyroids, in the female patients, the breast lumps, on the body anywhere, any soft tissue lump, deeper tissues like nodules in the lungs, liver, everywhere, wherever there's a mass lesion and we think it has to be biopsy, we can always proceed with cytology and then go in for a biopsies. For the superficial lesions, a blind procedure can be enough, like a cytopathologist can just go examine it and then easily take out the material and study it. But for deeper lesions, for example, if you're dealing with a lung nodule or a liver nodule, or a soft tissue nodule which is much below the muscular plane, okay, and it's not accessible, superficially accessible. In those conditions, we take the help of radiological investigations, like we do it either ultrasound guided or CTT guided. So whenever we use these investigations, they localize the lesions for us, and then when we put the needle in, we will know whether we are in the lesion or we have missed the lesion. So it also helps because the needle can also be seen under the instrument, like the USG or the CT will show where the needle is. So this gives us a clear cut whether we have reached the lesion and whether the needle has aspirated material from that. So with a guidance, that is with an image guidance mechanism, we are taking out the material and we are studying, okay. So this is the various kind of lesions from where we can take the tissue and we can study it. So now, why do we make use of FNACs? When we have a biopsy, it gives better results. Why do we can just proceed with that? Why do we do cytology, and why do we, there is a branch of pathology called as cytopathology? Because biopsy is tedious, okay. First of all, it is more invasive. Second, it needs a lot of surgical expertise. You need a surgeon to biopsy the particular specimen, and second, to process the biopsy specimen also we need a lot of instruments, okay. You need a tissue processor, you need a lab technician, you need to stain it, a staining process is required. Third is, it is time consuming. From the time sample is taken out from the patient till you process it and you study it and the report is given, it takes minimum 3 to 5 days or even more, okay. And again, it is traumatic to the patient because it is an invasive procedure. So because of all these things, cytology takes an upper hand because it is non-invasive. Maximum you just put a needle inside, so that is the pain the patient is going to go through, the prick of a needle. Second thing is, it can be done as an outpatient procedure. Even small setups in camps, primary health care, wherever, even in small setups, it can just be done easily by the doctor or with a cytopathologist, and this report can be given much earlier, like starting from 6 to 24 hours the report is ready and the report can be given. So this is because of all this, FNAC has gained popularity and FNAC is being widely practiced now. So in many cases, biopsy is difficult, time consuming and costly and requires surgical expertise, and as a result of this, FNAC has solved these problems. A simple 10 ml syringe can be used, no discomfort to the patient and very minimal bleeding. FNAC can be reported within 24 hours of sampling and gives easy and quick information to the surgeon. Also, the surgeon will very likely know that what is he dealing with. Assuming it is an infection or inflammation, he will just leave it, he won't go for a further testing. But if the report given it as a malignancy, definitely he will be going in for the further steps like a biopsy, and earlier the patient can be intervened and treatment can be given. So advantages we've already discussed, but let's just summarize. It's a very simple office techniques. It helps in rapid diagnosis. It is economical. Sampling from multiple sites can be done in the same setting. For example, 2 different lesions are there, a lesion in thyroid, lesion in the lymph node. At the same setting, 2 needles can be put, easily sample aspirated and diagnosis given. Or a person is having, say, a soft tissue swelling, multiple sides of the body, or from all the sides tissue can be taken and it can be studied. But whereas if a biopsy has to be done in some multiple sites, it becomes difficult, not only traumatic to the patient, even for the surgeon, and it's time consuming. So in that way, FNAC takes a upper hand. Second is high diagnostic accuracy. If the sample is taken from the representative site and if it's adequately processed and interpreted by a trained cytopathologist, okay, like the cytopathologist knows, he has adequate training and expertise, it is highly diagnostic. You really don't you have to go for a next thing like a biopsy or anything. Just the cytology will be sufficient for the diagnosis and for the further treatment of patient. Now another major advantage is the material which is used. It's not that you just stain it and give a report, but you can also use it for different things, like you can do a culture, you can do immunocytochemistry. So just like we have immunohistochemistry for biopsy specimens wherein the enzymes are targeted, so similar to that, the receptors of the enzymes are targeted in this cellular level, and you can do something called as the immunocytochemistry, and all the molecular tests like flow cytometry, cytogenetics, PCRs, all these are also possible from the FNAC material. Now coming to the limitations. So what are the limitations of FNAC is certain lesions, like for example, if a malignancy is proven, we really need to know whether it is in situ or invasive. So in situ means it is within the capsule or within a circumscribed area it is presented, it has not spread beyond that. Okay, invasive means it has crossed the capsule and it has spread. Now for all of this you really need to study it on a biopsy, but FNAC is not going to help you because we're just going to study the cell. So if it is within the cell, you just know it is abnormal or it is malignant, but we are not going to know about the invasion part. Similarly, capsular and lymphovascular invasion, okay, which is very important for metastasis, and capsular invasion, which forms an important thing for follicular neoplasm. To differentiate between follicular adenoma and a follicular carcinoma, we really need to know about the capsular invasion, that is a capsule of the tumor, whether it has been invaded or not. These kind of details, it is impossible to get it from the cytology, and a biopsy becomes mandatory in these conditions. And third thing is, you really need good expertise. That the cytopathologist who's reported a particular slides has to be trained, and he needs to have that appropriate expertise to report the slides, because he is going to see only the cells. When you have a biopsy, you have more area, like you have tissues, the abnormal tissue, the normal tissue, the surrounding area. So overall you can see a visualization area is more and the idea is more, and you can give a more correct and accurate report. But here it is just the cells, just the cell, and many mimickers will be there, like if it's a reactive cell or if it is a malignant, they almost look the same. So the expertise of the cytopathologist is very important. So a lot of training is required by the cytopathologist. So these are some of the few limitations of FNACs. Now these are the 4 fundamental requirements. If you want to do an FNAC, the 4 fundamental requirements is, first, the sample should be taken from the representative area, that is whichever is the lesion, wherever we are looking at, whichever is the suspicion, the area of suspicion, from that particular area it has to be taken out. So it has to be from the representative site. Second, sample must be adequate in terms of cells and tissue components, which means if I put on the needle and it starts bleeding, I get only the blood and no cells from that particular area, that particular FNAC is of no use, because I'm going to see only blood and blood elements and no cells from the representative site. So it should be adequately cellular. Third thing is, after you have collected, it should be properly smeared and properly processed. Okay, so that it has to be put in the fixator, it has to be smeared and properly stained. Only then the cytopathologist can report it. So the processing of the sample is extremely important. Last of all the history and examination. 50% of diagnosis of a slide from FNAC is from the history and examination. So a detailed history, detailed examination, along with any information on the radiological investigations like USG, CT, MRI, or the blood reports, whatever, all this has to be taken into consideration, and with this only we get half the TDs. The clinician will definitely help you, but you also when the patient comes to you, the FNAC is performed by a cytopathologist. So when the patient comes to you, the cytopathologist has to examine and make sure that history correlates, and then go in with the procedure. So all these are extremely important, are the fundamentals of performing a FNAC. Now in this picture we can see what is the instrument which is required. So here my pointer, if you can see my pointer, it will show you this is the needle, this is a piston, and this is a slide. Okay, and here you can see the needle is put inside the pistol. Okay, and you're holding it like a gunshot. So this will be the trigger which goes up and down. So this part of it is the mobile region. The needle which we use is the 22 to 23 gauge needle, and the syringe is generally a 20 ml or a syringe, because we need more amount of negative pressure or the suction. So the bigger the needle, more amount of suction we need. Okay, so that is the equipment. And then we need some sterile containers. For example, if you're taking it for processes like PCR or any molecular techniques, we need a physiological saline in a container wherein the aspirated material is put into it and then processed. Then you need salides which are clean, dry and free of grease. So always take a slide and rub it nicely with gauze piece, clean it and lay it on the table so that you can go proceed with the before all this has to be done before pricking the patient. And then you need the spreader slide. So once you take the slide and put the material into one slide, another slide is required to spread the tissue, and that is what's referred to as spreader slide. You can either make use of another slide, or a better thing will be a hemocytometer cover slip, because it is thin, so it gives a more perfect spread. But if it is not available, you can just process with another slide. And the fixative, after you perform the technique, so you can put it in fixative. The fixative which is used is most commonly used as a 70 to 90% ethanol, carnose fixative, 10% buffered formaldehyde, or glutaraldehyde can be used. And next what you do is you stain the smear. So there are different staining stains which are used, which I'll tell you later. So after you stain it, and then you require the microscopes for the cytopathologist to interpret it. Like he has to see it, observe it under the microscope, see it and give out the report. So these are the various instruments which are required to perform an FNAC. Now how do we perform FNAC? So basically there are two techniques. One is FNAC with aspiration and FNAC without aspiration. Even before you perform a technique, what is important is you need to first get an informed written consent, which means you talk to the patient, tell him what you're going to do, what is the procedure, what is the likely what are you going to do, what is the likely complication, and you ask the patient if you are agreeing to do the procedure. If the patient says yes, you please get it signed, you get a written informed consent. Okay. Second is, as I already emphasized before, get a detailed history, write down your examination findings. Another one important thing is just make sure the patient is on any blood thinners, because if you think the patient is on blood thinners, there can be some amount of bleeding. So all this is important when you ask the history. So once you're done with that, you take over and you have laid down the table, you have your glass sides ready, you have your sterile saline ready, you get your needle and the syringe and the piston, and then before that, this picture will show you. So let's see here, the person is taking out material from a lymph node. So in this particular where my pointer is showing, this is the pointer, and this particular area, this is a lymph node from where the material is going to be aspirated. So first thing will be cleaning it with the saline, with a spirit, surgical spirit, but take it in a cotton and clean the area nicely so that you make it completely sterile. And in this particular picture, the technician or the doctor has not worn the gloves, but always mandatorily it has to be gloved. Always your precautions has to be taken. So you put on the gloves, get the needle, and this method is with aspiration. So with aspiration, what we do is the needle is connected to the syringe, and then the needle is pricked into the lesion. So after you have fixed the lesion, that is, you get the swelling and you see, okay, fine, you are getting some firm swelling, and then you fix it. That is by fixing it with your 2 fingers. The right hand will be used for pricking, the left hand will be used for fixing the swelling. So you fix it with your index finger and the middle finger so that it doesn't move. If it moves away, you might go and hit some other region which is not representative. So you fix the swelling with your index and the middle finger, and then with the needle in your right, you put the syringe inside the region and you go multiple pricks up and down, like to and fro, go in and out, go in and out. And when you're doing this in and out, the syringe, this part of the syringe, this part, the piston should not be left, because if you're going to leave it, again it will go inside, the negative pressure will go off and the tissue cells will again be left inside the tissue. You don't need to happen. So this negative pressure has always to be maintained. So with the negative pressure being maintained, just go to and fro, suction it a little bit more, so more amount of cells come. Please don't keep on drawing blood. If it's bleeding, stop it immediately. If you're going to draw blood, you're going to dilute the cells with the blood elements. It becomes impossible for cytopathologist to report. We need is the dry tissue. Okay, we don't require any other elements. So whenever the bleeding is happening, immediately stop it. So here you can see in this picture, here you can see, so my negative pressure it is drawn, and you take it out in the next slide. The next what you do is, with the negative pressure maintained, you can remove it. Either you remove the hub of you remove the piston of it, and then you press it. Okay, then you push in air, and when you push in air, the material which is there in the hub of the needle comes and falls onto the slides. And once it falls onto the slide, you take another one slide. If you can see my pointer, another one slide, and you make a smooth smear, just how we make a blood smear. You make a smooth smear. Make sure that you don't crush the material and you don't make a thick smear. Evenly spread out the cells onto the smear so that it is a thin spreaded out smear. So this is with FNAC with aspiration. So here you can see the needle is put. Here the needle is put. This is a lesion. The round thing is a lesion. The needle is put. Here again you can see it's well within the lesion, and then you go a to and fro negative suction. And here what you're doing is you're removing the piston from the top so that the negative suction is maintained. And then what you're doing is slowly with the negative pressure maintained, removing the needle. And after that you take out the needle and you get some air into it, okay, into the syringe. You get some air into it, and then in this picture you can see you're pushing out all the material into the slide. So this is a method which is followed with FNAC with aspiration. Now this is without aspiration, which was introduced in 1987. Similar method, only thing is you make use of only the needle. So the needle, this is a lesion here. So you can see this is the needle here, and with the needle is going up and down, to and fro, and lesions the lesion, and here you're taking out the material. So this makes use of principle of the capillary pressure, that just when you put in by capillary pressure the cells get sucked into the needle, reaches the hub, and that which we put it onto the slide and you study it. Now failure to obtain what can happen, what is the problem? That is, some of the lesions which can happen is, so now in this picture you can see it is correct. It is correct, it's reached the lesion, but sometimes it can be tangential. Here you can see the needle has bypassed the lesion, it has gone beyond it, or that is, in that point again representative material is not obtained. In this you can see the center portion might have gone in for necrosis or hemorrhage or something where there are no actual viable cells to study. So if you take cells from this, you might not know what is happening to the particular patient, okay, because you have not reached the correct site. Here you can see this is a large benign lesion, this is a small malignant lesion in the periphery. Now this is very difficult to identify because you're going in blind. You won't know which is a tumor, which is the abnormal part, which is the normal part. So in these cases, an radiological imaging, that is image guided FNAC is really helpful. Either you can do a USG guided or you can do a CT guided FNAC, where you can actually localize where the particular lesion is and take material from that. And in this picture again you can see it's difficult because the whole thing has gone in for dysplasia or fibrosis, that has become like a hard tissue, and you really cannot aspirate any material. So these are certain things where technical errors, wherein the material you're not able to aspirate any material because of technical errors, okay. Now after this process is, next you go in for smearing. So smearing, there are two methods. One is a direct smearing or indirect smearing. For example, you have just taken the cells, put it onto the slide and smear it. So that is the direct smearing. But certain times what can happen is, like for example, you are in the thyroid and you aspirate some liquidy material, like some colloid has come. So in that, when you make a smear, there are hardly any cells. So then you have to go in for something called as the indirect smearing. Whereas in indirect smearing, what you are doing is, direct smearing you do it for creamy and consistency, consists of numerous cells suspended in small amount of tissue fluid. Wet, they are in more amount of fluid or blood. So in those cases you go for indirect smearing, where the fluid sample is processed by centrifugation. That is, you take 1 ml or 2 ml of colloid has come, or 1 ml of certain lesions where pus has come out, or whatever. In certain things, if there is a cystic swelling, the cyst fluid has come out. So in those conditions, take it and you centrifuge it, and after you centrifuge it with the deposit, you make a smear which is condensed and which has more amount of cellular things. So this is what is referred to as the indirect smearing. Direct, you put it in the slide and smear it. Indirect, you centrifuge it, and from the cell button you prepare the smear and you try to study the cells. Now how do you fixation and staining? So there are two methods, okay. So as soon as you've taken off the smear and you've taken off the material from the person and you have smeared it, so now there are two methods. One is either you can air dry it, or you can put it for wet, or you can put it for alcohol fixation. Air drying is nothing, you just leave the smear in the open, allow the smear to dry nicely. And what all stainings can be done in an air dry smear is, you can proceed with the MGG stain, Jenner stain, and quick stain, okay. So these are the common stainings, or the staining which we do with the air dried smears. Next we can do is alcohol fixation, where I already told you the fixatives, 70 to 90% alcohol, glutaraldehyde. So these are the fixatives which can be used, where you take the smear and you take a Copland jar, put it, fill it with the fixative, and then you put the smears inside the fixative. Okay, now what all stains can be done with this is you can do a pap stain or you can do an H&E stain. Okay, so these are the different stains which can be performed. Now why don't we do so many stains? Just you take a smear, just do one thing, like say I just do MGG and find out. Why do I have to do so many stains? The question is because each stain has different properties. Okay, for example, if you take a pap stain, it blows up your nuclear features. Okay, that if you want to see how the nuclear membrane is, if there's nucleoli, and study the nucleus, it's very good to see in the pap stain. But the disadvantage is it makes your nucleus look so big that you think it is abnormal. So in that stain, you always compare it with an H&E or with an MGG, so you get a clear idea. So it's always that when you have two 2-3 stains, you compare each and every slide and then collaborate all these features. A comprehensive report can be given, and that is the reason why we give it under we do different stains. In our hospital, what we do is whenever we obtain any material, we do 2 Giemsa or the Leishman stain, we do 2 H&E and 2 PAP, and if the material obtained is very less, we just do 1 of each. So 1 is for air drying and 2 is for alcohol fixation, where we do H&E and PAP. Now these are the stains. I'm not going to tell you in detail about stains because in subsequent classes you will be reading about pap staining. So this is a papaniculain stain. These are the contents: Harris hematoxylin, orange G6EA things. So in this, nucleus will be bluish in color, and if it is non-keratinizing, it will be a bluish green. If keratinizing, you will see in a pinkish orange turn. So this is about the Romanovsky stain, MGG or Giemsa, Jenner's, all this. The nucleus will be purple to blue, cytoplasm is pink. Okay, and then there's a Diffquick stain, which gives a modification of the Romanovsky stain, but it gives you it's used for some rapid staining procedure. Now this is about the MGG stain. Now there are certain special stains, like depending on the tissue. If you have you're getting some mucin, or there's some you're thinking of some iron pigments or melanin or whatever, so the special stains can be done, like PAS, Prussian blue, Mason's Fontana, Congo red, Zeal Nielsen, for identifying the acid fat bacilli. So these are the special stains which can be performed depending upon the case and depending upon the material which is aspirated. Now what are the complications of FNACs? Because it is a minimally invasive procedure, generally it is free of complications, but minor complications can be there, like bleeding. Sometimes if you have hit the vessel, so it can cause some amount of bleeding. So in those cases, best thing is just apply pressure. Just apply pressure to that particular area and eventually the bleeding will stop. Or it could lead to the formation of a hematoma. In very rare cases, if you're doing in lung, air can get entrapped and cause emphysema. And in few cases, like if you don't know there's a cystic lesion in the liver, it turns out to be hydatid cyst, you can have certain anaphylactic reactions. Very rarely noted, but yes, it has been encountered. These are the certain complications of FNAC. So that finishes the class about FNAC. So what is important is you need to know what FNAC stands for, what are the advantages, what are the limitations, how do we perform the procedure, after the procedure is performed, what happens to the tissue, how it is processed, how it is stained, and then interpretation of each thing is a different class. Like if it's FNAC of thyroid, salivary gland, there's a different class for that, how to study it and how to interpret it. So that's about the class today. Thank you.